Endosound. So this is the, I think, outside America, this is the first case to be done. The case is endosound similar to endoscopic ultrasound. We are using the upper scope, okay, and then we have the tip of ultrasound like the distal attachment. So that's what ultrasound will show it to you later. So and then with some of the angulations of the ultrasound. Then I will show you also the ultrasound AUS and then endoscopy at the same time, and I will give the chance to my colleagues here and my friend Carlos to explain more about the procedure. So I will try to do the procedure,
Oh yeah, for
and then
sure.
you can help us for any comments. So see, this is the attachment, this attachment with the connections of the wire as you see here. So this one, okay, can you focus a little bit here? See, and then this is the wheel of the attachment you see, and that of the endoscopy. You can control it if you need to perform FNA, FMB.
Yeah.
Okay. Then the movement mainly, I think it depends on the flexibility of the scope. Have a good flexibility, and then you can see. Did you have the ultrasound? You see, it's almost we are seeing the liver, seeing the IVC, and we're pushing. We see the portal. You can have a cursor here. The very obvious and very clear. I just moving the scope right and left, then pushing in. Then you know the landmark. Usually, you have to identify the celiac trunk. This is the celiac trunk, and this is the mesenteric down.
Concentric down.
It's very, very clear. You can see it. Did you appreciate case you can perform?
Well,
Yeah.
normally with this technology you can do it until 100 cases, and just you need to change the probe. There is the distal probe, and all the adapters and everything is, single use. Just the probe you need to reprocess, and then you can use it again. One of the things that is very interesting is also that
Ultrasound together.
you don't have the risk of of contamination, right?
Yes.
Bacterial contamination, because you don't use elevator. You use the same probe as elevator uh, to use the needle when you are using or performing an FNA or FMB. That is one of
So
the
you
big
think that
advantages.
mucocystis or strand or cystic lesion or atrophied pancreas, as you know, the solid criteria of chronic pancreatitis is lobularity and also some stones. So what do you think, Laurent and Harris?
Yeah, it's compatible. Yeah, early. Yeah, yeah.
Yes. So what we will do now, we'll show you. I have to advance to the duodenum, and then we have to go the scope out. We'll show you the tip of the scope. Now, yeah. So
Here
now
it's
it's
a little bit.
yeah. So the advantages of
Well,
yeah,
I think Laurent already said it's the cost.
cause and infection contaminations also.
Yeah, cross contamination, and also I think one of the big. Well, I think this is the first step for next generation of endoscopic ultrasound machines. Is, well, we can say it's portable, right? You can bring with you. It's a small box. So here we can see the gallbladder. Oh, I think there is some slush inside. Yeah, yeah, yeah. F5, F5, F5. Yes.
F5.
Yeah, we have Doppler. Yeah.
So, Laurent, what do you think about the quality of imaging?
I say it's acceptable. So after it's the
There is a
okay,
sound there in
yeah,
the.
the stone. But I will take it some seconds
Yes, please.
to have it. So no balloon, of course.
No balloon.
So the air is more the enemy. But I never put air. So yes, it's chronic pancreatitis.
Chronic pancreatitis. Yes.
You see?
There is a chronic pancreatitis in this patient.
Yeah. It's a chronic pancreatitis. Look. You see that the duct irregular. You see the duct. You
Yeah.
see the duct.
Can
It's
you hear us, Sam?
irregular. Yeah.
Yes.
Yeah.
He needs to respond this.
So the first time I used it, it was very easy. It's similar to any other devices.
So you have this adapter, right? That is in the tip of the scope of the standard gastroscope. I use it already in in therapeutic scope, gross therapeutic scope. But nowadays we have working channel, better working channel, 3.2, and it's enough. The thing here is that you have this adapter. This is plastic, and you remove and take out, just single use. And you have this. You can see here. So this is for when you pass the needle. So you pass the needle, and once you pass the needle, you put again the scope, and this will be your elevator, right? So you do it exactly in the same way that you are doing, upper US linear, and I believe it's cheaper and it's very interesting and attractive to do, even for diagnosis or these kind of cases that we find out early chronic pancreatitis, right?
Yeah.
So what do you think?
I think that the image is.
If he say that the image is good,
Yeah.
I believe him,
Yeah,
right?
yeah, yeah. It's a good
He's
image.
he's
We
the
cannot
father of
say
the
it's not a
US.
good image. It's a good image. Of course, you have fantastic image now, but it's the question of price. So it's cheap, so the image is good. You can work, and if we can have Wi-Fi and not
Okay.
this, it will be more
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 interesting,
more
right?
interesting, more effective, more easy. So I think it's the beginning of the story,
Yes.
but already this thing is working.
Yes. No, you can go easy because you have front view. You have front view of the scope, so you pass exactly similar that you are doing upper endoscopy. That's all.
And
You make a small insufflation and you go there. That's all. Well, the disadvantage is in some cases it's difficult to pass the second portion, or when you try to see the uncinate process in some kind of patients, it's difficult. But it's just like as a, as a Professor Palazzo already said, you need some tips. You need to maneuver some time, and then you get it. And once you get it, you will go and move easier. That's all.
special station, yes.
Well, Well, this is for beauty, right? But to be honest, you can disconnect here, but the box is a small box. So in the future, probably we don't need, we need the monitor, right? But in the future, adapt other kind of technology will be easier. So it's but it's okay. Thank you.